Management of sickle cell disease in pregnancy. Green Top Guideline number 61, July 2011. Background and introduction. Sickle cell disease is a group of inherited single-gene autosomal recessive disorders caused by the sickle gene, which affects hemoglobin structure. SCD has its origin in sub-Saharan Africa and the Middle East, hence it is most prevalent in individuals of African descent, as well as in the Caribbean, Middle East, parts of India, and the Mediterranean, and South and Central America. Owing to population migration, SCD is now of increasing importance worldwide, and there are increasing numbers of affected individuals in Europe and the USA. The term SCD includes sickle cell anemia and the heterozygous conditions of hemoglobin S and other clinically abnormal hemoglobins. These include combination with hemoglobin C, combination with beta thalassemia, and combination with hemoglobin D, E, or O Arab. All of these genotypes will give a similar clinical phenotype of varying severity. Hemoglobin S combined with normal hemoglobin A, known as sickle trait or AS, is asymptomatic except for a possible increased risk of urinary tract infections and microscopic hematuria. Sickle cell disease is the most common inherited condition worldwide. About 300,000 children with sickle cell disease are born each year. Two-thirds of these births are in Africa. In the UK, it is estimated that there are 12,000 to 15,000 affected individuals and over 300 infants born with SCD in the UK each year who are diagnosed as part of the neonatal screening program. There are approximately 100 to 200 pregnancies in women with SCD per year in the UK. Pregnancy outcome in this group is currently being assessed by the UK Obstetric Surveillance System. The pathophysiology of sickle cell disease is a consequence of polymerization of the abnormal hemoglobin in low oxygen conditions, which leads to the formation of rigid and fragile sickle-shaped red cells. These cells are prone to increased breakdown, which causes the hemolytic anemia, and to vasoocclusion in the small blood vessels, which causes most of the other clinical features, including acute painful crisis. Other complications of sickle cell disease include stroke, pulmonary hypertension, renal dysfunction, retinal disease, leg ulcers, cholelithiasis, and a vascular necrosis, which commonly affects the femoral head and may necessitate hip replacement. Pre-conception care. What are the additional risks to the woman and baby? Sickle cell disease is associated with both maternal and fetal complications and is associated with an increased incidence of perinatal mortality, premature labor, fetal growth restriction, and acute painful crisis during pregnancy. What is the importance of planning pregnancy, and how can outcomes for the woman and baby be improved? From adolescence, The intentions of women with sickle cell disease regarding pregnancy and contraception should be documented at each contact with our sickle care team. Women with sickle cell disease should be seen preconceptually by a sickle specialist to receive information about how sickle cell disease affects pregnancy and how pregnancy affects sickle cell disease and how to improve outcomes for mother and baby. These consultations should include optimization of management and screening for end organ damage. Primary care physicians have a key role in preconceptual screening, including the provision of contraceptive advice. Women with sickle cell disease should receive not only the general preconceptual care, which is given to all women, but also additional advice about vaccinations, medications, and crisis avoidance. Advise women to have a low threshold for seeking medical help. Information that is particularly relevant for women planning to conceive includes the role of dehydration, cold, hypoxia, overexertion, and stress in the frequency of sickle cell crisis. How nausea and vomiting in pregnancy can result in dehydration and the precipitation of crisis. The risk of worsening anemia, the increased risk of crisis in acute chest syndrome or ACS, and the risk of increased infection, especially urinary tract infection during pregnancy. The increased risk of having a growth-restricted baby, which increases the likelihood of fetal distress, induction of labor, and cesarean section. The chance of their baby being affected by sickle cell disease, and an up-to-date assessment for chronic disease complications. The assessment for chronic disease complications should include screening for pulmonary hypertension with echocardiography, a tricuspid regurgitant jet velocity of more than 2.5 meters per second is associated with a high risk of pulmonary hypertension. Blood pressure and urinalysis should be performed to identify women with hypertension and/or proteinuria. Renal and liver function tests should be performed annually to identify cecal nephropathy and/or deranged hepatic function. Retinal screening. Proliferative retinopathy is common in patients with sickle cell disease, especially patients with hemoglobin sickle cell disease, and can lead to loss of vision. There is no randomized evidence on whether routine screening should be performed or if patients should be screened only if they experience visual symptoms, but we recommend that women are screened preconceptually. Screening for iron overload. In women who have been multiply transfused in the past or who have a high ferritin level, T2 star cardiac magnetic resonance imaging may be helpful to assess body iron loading. Aggressive iron chelation before consumption is advisable in women who are significantly iron loaded. Screening for red cell antibodies. Red cell antibodies may indicate an increased risk of hemolytic disease of the newborn. What is the importance of genetic screening and what procedure or procedures are involved? Women and men with sickle cell disease should be encouraged to have the hemoglobinopathy status of their partner determined before they embark on pregnancy. If identified as an at-risk couple, as per National Screening Committee guidance, they should receive counseling and advice about reproductive options. Women should be encouraged to have the hemoglobinopathy status of their partner tested. If a partner is a carrier of or affected by a major hemoglobinopathy, the couple should receive appropriate counseling regarding the risk of having affected offspring. In addition, they should receive counseling about the availability of pre-implantation genetic diagnosis. Women with sickle cell disease should be aware that if their partner's status is unknown, the fetus should be treated as high risk for a hemoglobinopathy. Sperm donors should also be screened for hemoglobinopathies for couples considering in vitro fertilization. What is the importance of antibiotic prophylaxis and immunization? Penicillin prophylaxis or the equivalent should be prescribed. Vaccination status should be determined and updated before pregnancy. Patients with sickle cell disease are hyposplenic and are at risk of infection, in particular from encapsulated bacteria such as Neisseria meningitidis, Streptococcus pneumonia, and Haemophilus influenza. UK guidance is that daily penicillin prophylaxis is given to all patients with sickle cell disease in line with the guidelines for all hyposplenic patients. People who are allergic to penicillin should be recommended erythromycin. Women should be given Haemophilus influenza type B and the conjugated meningococcal C vaccine as a single dose if they have not received it as part of primary vaccination. The pneumococcal vaccine, such as Pneumovax, should be given every 5 years. Hepatitis B vaccination is recommended, and the woman's immune status should be determined preconceptually. Women with sickle cell disease should be advised to receive the influenza and swine flu vaccine annually. What vitamin supplements should be given? Folic acid of 5 milligrams should be given once daily, both preconceptually and throughout pregnancy. Folic acid at a dosage of at least 1 milligram daily is recommended for women with sickle cell disease outside pregnancy in view of their hemolytic anemia, which puts them at increased risk of folate deficiency. What medications should be reviewed preconceptually? Hydroxycarbamide or hydroxyurea should be stopped at least 3 months before conception. Angiotensin converting enzyme inhibitors and angiotensin receptor blockers should be stopped before conception. Hydroxycarbamide has been demonstrated to decrease the incidence of acute painful crisis and acute chest syndrome in individuals with severe clinical manifestations of sickle cell disease. Hydroxycarbamide is teratogenic in animals, and consequently, current UK advice is that women with sickle cell disease on hydroxycarbamide should use effective contraception and stop taking hydroxycarbamide 3 months before they conceive. Antenatal care. General aspects. Antenatal care should be provided by a multidisciplinary team, including an obstetrician and a midwife with experience of high-risk antenatal care and a hematologist with an interest in sickle cell disease. Women with sickle cell disease should undergo medical review by the hematologist and be screened for end organ damage if this has not been undertaken preconceptually. Women with sickle cell disease should aim to avoid precipitating factors of sickle cell crisis, such as exposure to extreme temperatures, dehydration, and overexertion. Persistent vomiting can lead to dehydration and sickle cell crisis, and women should be advised to seek medical advice early. The influenza vaccine should be recommended if it has not been administered in the previous year. Antenatal hemoglobinopathy screening. If the woman has not been seen preconceptually, she should be offered partner testing. If the partner is a carrier, appropriate counseling should be offered as early as possible in pregnancy, ideally by 10 weeks of gestation, to allow the option of first trimester diagnosis and termination if that is the woman's choice. What medication should be given during pregnancy? If women have not undergone a preconceptual review, they should be advised to take daily folic acid and prophylactic antibiotics if not contraindicated. Drugs that are unsafe in pregnancy should be stopped immediately. Iron supplementation should be given only if there is laboratory evidence of iron deficiency. Women with sickle cell disease should be considered for low-dose aspirin of 75 milligrams once daily from 12 weeks of gestation in an effort to reduce the risk of developing preeclampsia. Women with sickle cell disease should be advised to receive prophylactic low molecular weight heparin during antenatal hospital admissions. What additional care should be provided during the antenatal appointment? Antenatal appointments for women with sickle cell disease should provide routine antenatal care as well as care specifically for women with sickle cell disease. Blood pressure and urinalysis should be performed at each consultation and midstream urine for culture performed monthly. Women with sickle cell disease probably have an increased risk of pregnancy-induced hypertension. Therefore, blood pressure and the presence of proteinuria should be assessed at each visit. What is the recommended schedule of ultrasound scanning during pregnancy? Women should be offered a viability scan at 7 to 9 weeks of gestation. Women should be offered the routine first trimester scan, 11 to 14 weeks of gestation, and a detailed anomaly scan at 20 weeks of gestation. In addition, women should be offered serial fetal biometry scans or growth scans every 4 weeks from 24 weeks of gestation. What is the role of blood transfusion during pregnancy? Routine prophylactic transfusion is not recommended during pregnancy for women with sickle cell disease. If acute exchange transfusion is required for the treatment of a sickle complication, it may be appropriate to continue the transfusion regimen for the remainder of the pregnancy. Blood should be matched for an extended phenotype, including full rhesus typing, C, D, and E, as well as KEL typing. Blood used for transfusion in pregnancy should be cytomegalovirus negative. What is the optimal management of acute painful crisis during pregnancy? Women with sickle cell disease who become unwell should have sickle cell crisis excluded as a matter of urgency. Pregnant women presenting with acute painful crisis should be rapidly assessed by the multidisciplinary team, and appropriate analgesia should be administered. Betadine should not be used because of the associated risk of seizures. Women admitted with sickle cell crisis should be looked after by the multidisciplinary team involving obstetricians, midwives, hematologists, and anesthetists. The requirement for fluids and oxygen should be assessed, and fluids and oxygen administered if required. Thromboprophylaxis should be given to women admitted to hospital with acute painful crisis. Painful crisis is the most frequent complication of sickle cell disease during pregnancy, with between 27% and 50% of women having a painful crisis during pregnancy, and it is the most frequent cause of hospital admission. Avoidance of precipitants such as cold environment, excessive exercise, dehydration, and stress is important. Mild pain may be managed in the community with rest, oral fluids, and paracetamol or weak opioids. Non-steroidal anti-inflammatory drugs should be used only between 12 and 28 weeks of gestation. Primary care physicians should have a low threshold for referring women to secondary care. All women with pain which does not settle with simple analgesia, who are febrile, have atypical pain or chest pain, or symptoms of shortness of breath should be referred to hospital. History should ascertain if this is typical sickle pain or not, and if there are precipitating factors, in particular whether there are any signs of infection. Initial investigation should include full blood count, reticulocyte count, and renal function. Other investigations will depend on the clinical scenario, but may include blood cultures, chest x-ray, urine culture, and liver function tests. Initial analgesia should be given within 30 minutes of arriving at hospital, and effective analgesia should be achieved within 1 hour. The World Health Organization analgesic lather should be used, starting with paracetamol for mild pain. Non-steroidal anti-inflammatory drugs can be used for mild to moderate pain between 12 and 28 weeks of gestation. Weak opioids such as codidramol, cocodamol, or dihydrocodeine can be used for moderate pain, and stronger opiates such as morphine can be used for severe pain. Morphine or dimorphine can be given by the oral, subcutaneous, intramuscular, or intravenous route depending on the woman's preference and local expertise. Parenteral opiates can be given by intermittent bolus or patient-controlled administration systems. Women presenting with pain should initially be monitored at 20-minute intervals for pain severity, respiratory rate, and sedation. Women whose pain settles following oral analgesia can be discharged home. If the woman needs strong opiate therapy, they will need to be admitted to hospital, to a medical ward in early pregnancy, or to a level 2 antenatal bed in later pregnancy under the joint care of obstetricians and hematologists. Fluid intake of at least 60 milliliters per kilogram over 24 hours should be ensured. This can be taken either orally or intravenously if the woman is not able to take adequate oral fluids. Oxygen saturations should be monitored, and facial oxygen should be prescribed if oxygen saturation falls below the woman's baseline or below 95%. The woman should be assessed for infection. Therapeutic antibiotics should be prescribed if the woman is febrile or there is a high clinical suspicion of infection. White blood cell counts are often raised in sickle cell disease and do not necessarily indicate infection. Thromboprophylaxis should be provided to women with sickle cell disease who are admitted to hospital with painful crisis. Other adjuvants may be required to treat the adverse effects of opiates, such as antihistamines to treat itching or laxatives to prevent opiate-induced constipation, and antiemetics may be required. Opiates are not associated with teratogenicity or congenital malformation, but may be associated with transient suppression of fetal movement and a reduced baseline variability of the fetal heart rate. Where a mother has received a prolonged administration of opiates in late pregnancy, the neonate should be observed for signs of opioid withdrawal. Box number 1. Outline of management of acute pain. Rapid clinical assessment. If pain is severe and oral analgesia is not effective, give a strong opioid such as morphine. Give adjuvant non-opioid analgesia, paracetamol, or non-steroidal anti-inflammatory drugs if 12 to 28 weeks of gestation. Prescribe laxatives, antipruritic, and antiemetic if required. Monitor pain, sedation, vital signs, respiratory rate, and oxygen saturation every 20 to 30 minutes until pain is controlled and signs are stable. Then monitor every 2 hours, hourly if receiving parenteral opiates. Give a rescue doses of analgesia if required. If respiratory rate is less than 10 per minute, omit maintenance analgesia, consider naloxone. Consider reducing analgesia after 2 to 3 days and replacing injections with equivalent dose of oral analgesia. Discharge the women when pain is controlled and improving without analgesia or on unacceptable doses of oral analgesia. Arrange any necessary home care in outpatient follow-up appointment. What are the other acute complications of sickle cell disease and how are they treated? All patients, carers, medical and nursing staff should be aware of the other acute complications of sickle cell disease, including acute chest syndrome, acute stroke, and acute anemia. Each hospital should have a protocol in place for the management of acute chest syndrome in pregnancy, including the use of transfusion therapy. After acute pain, acute chest syndrome or ACS is the most common complication reported in 7 to 20% of pregnancies. ACS or acute chest syndrome is characterized by respiratory symptoms such as tachypnea, chest pain, cough, and shortness of breath in the presence of a new infiltrate on the chest X-ray. The signs and symptoms of acute chest syndrome are the same as those of pneumonia, so both should be treated simultaneously. Early recognition of acute chest syndrome is key. Treatment is within intravenous antibiotics, oxygen, and blood transfusion, as in non-pregnant women. Top-up blood transfusion may be required if the hemoglobin is falling and certainly if the hemoglobin is less than 6.5 grams per deciliter, but in severe hypoxia, and if the hemoglobin level is maintained, exchange transfusion will be required. If acute chest syndrome is suspected, the woman should be reviewed urgently by the hematology team to advise on transfusion. If the woman has hypoxia, she should be reviewed by the critical care team and ventilatory support may be required. There is an increased risk of pulmonary embolism among women with sickle cell disease. In women presenting with acute hypoxia, there should be a low threshold for considering a pulmonary embolism. In this situation, therapeutic low molecular weight heparin should be commenced until the woman has been reviewed by senior staff and definitive investigations have been undertaken. Acute stroke, both infarctive and hemorrhagic, is associated with sickle cell disease, and this diagnosis should be considered in any woman with sickle cell disease who presents with acute neurological impairment. Acute stroke is a medical emergency, and a rapid exchange blood transfusion can decrease long-term neurological damage. If a stroke is suspected, The woman should have urgent brain imaging, and the hematologist should be called for consideration of urgent exchange transfusion. Thrombolysis is not indicated in acute stroke secondary to sickle cell disease. Acute anemia in women with sickle cell disease may be attributable to erythrovirus infection. Infection with erythrovirus in sickle cell disease causes a red cell maturation arrest and anaplastic crisis characterized by a reticulocytopenia. Therefore, a reticulocyte count should be requested in any women presenting with an acute anemia, and if low, may indicate infection with erythrovirus. Treatment is with blood transfusion, and the woman must be isolated. With erythrovirus infection, there is the added risk of vertical transmission to the fetus, which can result in hydrops fetalis, hence a review by a fetal medicine specialist is indicated. Intrapartum care. What is the optimal timing and mode of delivery? Pregnant women with sickle cell disease who have a normally growing fetus should be offered elective birth through induction of labor or by elective cesarean section if indicated after 38 plus 0 weeks of gestation. Sickle cell disease should not in itself be considered a contraindication to attempting vaginal delivery or vaginal birth after cesarean section. Blood should be cross-matched for delivery if there are atypical antibodies present, since this may delay the availability of blood. Otherwise, a group and save will suffice. In women who have hip replacement because of avascular necrosis, it is important to discuss suitable positions for delivery. What is the optimum care in place of birth for a woman with sickle cell disease? Women with sickle cell disease should be advised to give birth in hospitals that are able to manage both the complications of sickle cell disease and high-risk pregnancies. The relevant multidisciplinary team, senior midwife in charge, senior obstetrician, anesthetist, and hematologist should be informed as soon as labor is confirmed. Women should be kept warm and given adequate fluid during labor. Continuous intrapartum electronic fetal heart rate monitoring is recommended owing to the increased risk of fetal distress, which may necessitate operative delivery. During labor, if oral hydration is not tolerated or is inadequate, intravenous fluids should be administered using a fluid balance chart to prevent fluid overload. Venous access can be difficult, especially if they have had multiple previous admissions, and as such, anesthetic review or intravenous access should be obtained early. The demand for oxygen is increased during the intrapartum period, and the use of pulse oximetry to detect hypoxia in the mother is appropriate during labor. Arterial blood gas analysis should be performed and oxygen therapy instituted if oxygen saturation is 94% or less. Routine antibiotic prophylaxis in labor is currently not supported by evidence, but hourly observations of vital signs should be performed. A raised temperature over 37.5 degrees Celsius requires investigation. The clinician should have a low threshold to commence broad-spectrum antibiotics. What is the optimal mode of analgesia and anesthesia? Women with sickle cell disease should be offered anesthetic assessment in the third trimester of pregnancy. Avoid the use of pethidine, but other opiates can be used. Regional analgesia is recommended for cesarean section. Postpartum care. What should be the optimum care post-delivery? In pregnant women where the baby is at high risk of sickle cell disease, for example, the partner is a carrier or affected, early testing for sickle cell disease should be offered. Capillary samples should be sent to laboratories where there is experience in the routine analysis of sickle cell disease in newborn samples. This will usually be at a regional center. Maintain maternal oxygen saturation above 94% and adequate hydration based on fluid balance until discharge. Low molecular weight heparin should be administered while in hospital and 7 days post-discharge following vaginal delivery or for a period of 6 weeks following cesarean section. What postpartum contraceptive advice should women be given? Progesterone-containing contraceptives, such as the progesterone-only pill, like Cerazette, injectable contraceptives, Depo-Provera, and the levonorgestrel intrauterine system or Mirena, are safe and effective in sickle cell disease. Estrogen-containing contraceptives should be used as second-line agents. Clinical governance. Each hospital should have a protocol for the management of pregnant women with sickle cell disease. This should identify a multidisciplinary team which has responsibility for the care of pregnant women with sickle cell disease, including an obstetrician with expertise in managing high-risk pregnancies and a hematologist. All staff involved in maternity care should receive training in the care of pregnant women with sickle cell disease. Areas with a low prevalence of sickle cell disease should be linked to a specialist center or care network for shared care arrangements and shared protocols.